The biggest change in breast pathology has come over the last, say, 15 years, really. I mean, there's nothing new specifically today, but the shift towards doing core biopsies has made a huge impact in both how we diagnose things and what the meaning of our diagnoses are. Right? We biopsy smaller and smaller lesions that are picked up radiologically that are not only cancers but are risk factors or are not risk factors or totally benign things. And the pathologist has become the sort of gatekeeper, if you will, of whether the patient actually goes to surgery or not. And one of the biggest advantages of core biopsies is the fact that we actually prevent a lot of surgery that would have been done before for completely benign lesions. That all being said, it has sort of gotten, at least me, away from the sort of tunnel vision, if you will, that a pathologist might have by coming in every day and just looking through the tube of his microscope all day long, where it forces us to think about things in a bigger picture, in a radiologic picture, and a clinical picture of what's going to happen to this patient depending on the diagnosis I make. Will she have more frequent mammography? Will she have surgery? Will she have tamoxifen? Not just is it cancer, is it not cancer? It gets much more complicated, and it forces us to think in a more multidisciplinary way. And that, in fact, is why I come to this meeting a lot. And every time I come to this meeting, it makes me think about a couple of diagnoses that I make every day in a little different way. And today is actually no exception. The problem we have with reimbursement in pathology is twofold. Basically, reimbursement is supposed to be based on the amount of work that you put in. So we have a very limited set of billing codes that Medicare has dictated over the years. And they have very little to do with the amount of work that actually gets put in. For example, the billing code for interpretation of a biopsy, a breast core biopsy, is exactly the same billing code as it is for a skin biopsy. Now, or for a colon polyp biopsy or any number of other things. For the vast majority of skin biopsies for a benign entity like a seborrheic keratosis, that will take about less than a second, maybe, to diagnose. I mean, off the microscope, like that. Whereas a breast core biopsy, which ordinarily in most people's hands is at least 4 levels, 4 sections, 4 slides, perhaps many more, perhaps 8, 10, 12. If I'm looking for calcifications, I might cut many, many more sections of the same paraffin block after x-raying the block, and it could be an hour's worth of work, if not more, but I get exactly the same reimbursement. Furthermore, talk about surgery. This sounds opposite of what it should. I would much rather look at a mastectomy specimen any day than a lumpectomy specimen, because a mastectomy specimen, for me, from my point of view, takes hardly any time at all. I mean, I don't have to worry about margins. Right? All I have to worry about is the diagnosis, size of the tumor, a couple of other things. It is relatively small in numbers of slides, but I don't have to deal with margins. Whereas a lumpectomy specimen, particularly if it's for DCIS, for intraductal carcinoma, I might have to look at every single piece of tissue that comes out, which could be 50, 60, 70, 80 slides, and I have to worry about margins on each one, and I have to worry about any number of different things. Believe me, it takes far more time and effort, both grossing the specimen and microscopically than the mastectomy. But guess which one gets reimbursed at a higher rate? The mastectomy. So it's all backwards.